Hi, good morning, everyone. My name is Ren-Dih. I work with Dr. Stock and Dr. Stone in the past 15 years. And it's an honor for me to join this meeting with everyone when I realize not that many physical colleagues are here. So today I'm going to present the physics of the intraoperative dose planning for focal brachytherapy. So first, I have nothing to disclose, no commercial relationship. Yeah, so everybody knows this image with MRI with a sizable lesion inside. So when we consider the treating this size of the lesion, that prostate size is normally within like a few cc, and the target we're treating is like this centimeter dimension. So when we look at how to treat this type of the cancer, what choice we have? So first, of course, the LDR seeds, we use this radioactive material, so they release like a low dose photon energy. So their energy will deposit in the target and they gradually decay and release all the energy and destroy all the tumor lesion. So this is a preferable choice. And another choice is very popular is using this external beam radiation therapy. So we have these two choices, especially we're talking about the stereotactic radiosurgery. It also can give very high focal and a concentrated dose. But which one is more preferable? So let's go to the physics. So if you are looking at the dose fall off, this is the graph we plot. The green line is dose along the axis. So we normalize to 5 millimeter from the C. So this we normalize to 100%. So you can see the dose drop off. Within 1 cm, it's drop off less than 50% of the dose. So this is highly rapid dose fall off is ideal choice for this focal therapy in this small region to treat. And this one, the orange line, this orange line is come from a 6 MV cranial SRS. We use 6 different arcs and with 6 different couch kick to create a highly dose fall off distribution to treat a target. But you can see it's also drop off really fast, but within 1 cm it drop off 50%. But compared to the brachy it drop off is fast. And you can see this is using like almost 2 pi angle. It will be hard to apply for the prostate in the body region. So this figure you can see the brachy source is more preferable for this focal therapy. Yes, so if we try to do a successful focal brachytherapy, what do we need? First, of course, we have many presentations already talk about how to locate all the prostate cancer, the target. We cannot just rely on the MRI. We do need a biopsy and the multiple imaging modality to create this environment to treat this focal therapy. And the next one is how about radiation dose? So we have this brachy source. We have the opportunity to deliver higher dose when we're treating a smaller volume. And how high should we go? We'll take a look at it. And then the next part is how about the organ at risk? When we bring up the dose, we still need to maintain all these organs at risk in the accepted dose level. Then how do we do that? I'm going to address in this presentation as well. So first, this is the study done by Dr. Stone and us. We're looking at the factor associated with the late focal local failure and its influence on survival in men undergoing prostate brachytherapy. This was submitted to the brachytherapy accepted last year. So this study is overlapped with the presentation Dr. Stone just presented. This is a post-implant transrectal and transperineal biopsy in 545 men. It's a late biopsy, The time to biopsy mean is about 6.7 years, range from 2 to 17 years. And the follow-up median of 11.4 years. And the overall positive biopsy rate is 8.8%. So on the left side, the figure shows the comparison of the freedom from the PSA failure for the men with negative and versus the positive biopsy. So you can see there's a significant difference between these two. And the plot on the right is the comparison of the cancer-free survival from men with the negative and versus the positive biopsy. So you can see these two groups, they are separated. So the negative biopsy is a good surrogate for us to see if the this dose is is enough. So in this study, we look into the dose level to different group. First, we look at the patient who receive less than 150 BED. They have the 15.2 positive rate. And the patient who receive 150 to 200 BED, the positive rate is decreased to 6.1%. And the last group is the patient who received the BED greater than 200. The positive rate is dropped to 1.6. So clearly you can see when the BED increase the patient receive, their positive rate drop. That means the negative rate comes up. All right, so then we further separate it into two groups. We find out the patient who receive less than 220 BED, they still have a 7.4 positive rate. So we're trying to find out what the BED need to have the negative biopsy. So that's the 220. That's where this BED 200 comes from. So it has the 0 positive biopsy rate. So Dr. Stone, we also look into the linear regression variables influence biopsy result. So all this initial PSA, clinical stage, Gleason score, and hormone therapy, all of them are not statistical significant except the total BED. The total BED is the only factor of affect this biopsy result. Yeah, so how we know this 220 BED, then how do we prescribe it in the clinic? Because we're using different type of seed and different type of the prescription. So when you talk to your physicist, what the dose you need to do. So I list this table here. So I list the 3 different BED level, and for different type of the isotope, I list the iodine 125, palladium 103, and the cesium 131. And I also list the conventional external beam and the SBRT here. So how do we get this number? I'm going to describe it in the next 2 slides, and then I'll come back to these slides later. So to calculate it, we use the BED formula, which is published by Dr. Stock and Dr. Stone back in 2006. I'm sorry to put the formula in the early morning, but if you look at the formula, actually is not that complicated. It looks complicated, but it's not that complicated. So some of them are constant because we're looking at the prostate only. So the prostate repair rate is a constant for prostate, and the tissue repair half-life is the same for prostate. So the only thing changed, and it depends on the isotope. So only thing changed is their half-life, and the radioactive decay constant is actually a function of half-life. So you can derive what's the D90 you need from that the magic 220 BED. So you can derive for different type of the isotope. And I also listed the BED for external beam because I want to show the difference between them. So for the external beam, the formula is even simpler. So all the detail you can find in Dr. Stock's paper. So this formula, because the alpha ratio is just, we use 2 for prostate, and then the only two variable is just number of fraction and the dose per fraction. So let's come back to this slice. So now we know how we calculate this 220 BED. So we can calculate for different isotope. So that would be 207, which is the one Dr. Stone used for his focal therapy, the prescription dose, physical dose. And if you choose in the other isotope, you can use palladium, you can use cesium. So it can all be calculated using the different the physical dose for you to prescribe. So from here, you can look at like Dr. Stone showed earlier, the external beam, the dose is much higher than the regular you see here. It's almost 40%. And to just think about the you need to deliver much higher dose than all the Linac MU, you need 40%, you just need to add 40% MU more. But if you look at the Dr. Stone's result, when you do the using the brachy seed, you will notice, I don't know if you notice, you would notice the activity and the seed number actually is not increased. You are not putting 40% more seed, or you order, call the company, order 40% of the more seed. Because of the nature of physics, the seed just give you much higher dose in a shorter distance. So that's why I want to bring up here. Okay, so now we know how to prescribe. We have this 220 BED. Then how do we do with the OAR? So for go back to the basic. So how do we do radiation protection? So we have a 3 option. So we limiting the time, or increasing the distance, or just using shielding. But everybody knows that in our case, it's hard to limit the time, or using the shielding between the prostate and the bladder. So the only variable option is increasing the distance. So I think Dr. Stone already presented this. I don't want to go over again. So the detail Dr. Stone already presented. This is the study they did back in 2021. They implant use the LDR to the focal therapy in the phantom. So so I'm going to skip this slide. So the protocol, I just want to mention this protocol. So you will notice that we are Dr. Stone using the iodine 125 seed and trying to aim for this physical dose 107, which is the 220 BED we described earlier. So everything this Dr. Stone already described, they did the implant in the OR, then take the phantom to the CT scan, get the first post-implant dosimetry, and then bring back to the OR and inject the space agent, and take back to the CT scan the second time to see the difference. So from the result, you can see, Dr. Stone already presented this. I don't want to repeat, but I want to point out this is important. So you see the total number of the seed and the activity we're using it. It's actually 0.5 millicurie, or you can see it's 0.635. It's not that much higher than what we use. So you can actually achieve the activity by using the similar activity. And that as Dr. Stone described, the number of the seeds, you don't see a dramatic increase in the total number of the seed, because within using the seed layout and Intraoperative perform this procedure, you can see how the isodose lines change in real time. So that's really helpful. So this is the result. You can see this was the insert the barrier gel, the spacer in between. So you can see this purple line. I know this phantom, the prostate and the rectum distance was a little far away, but you can see if you use this purple line as an indicator, you can see in this case without the spacer in between, the purple line is touching the the rectum, and this 40 gray is just a 20% line is go into the rectum really far. And this just on the different slices. And this is after the post barrier gel injection, so you can see the gel created the space in between the prostate and the rectum. So this original, this purple 80 gray line is touching the rectum. Right now is no longer touching, and it just creates spacing and pull out this isodose line away from the rectum. So that can create the environment to bring up the dose without damage the organ at risk nearby. Yeah, so in the conclusion, based on the biopsy data, men treated with focal brachytherapy who should receive a BED of 220 grade to the CTV. And I have showed that if you're using a different isotope, what the physical dose we should prescribe to. And the prior identification of region contain the Gleason score 2 or grade suggests majority of treatment involve posterior of the gland. And also we try to, when in the meantime we bring up the dose, we should use the spacer, should reduce the risk of radiation injury because we are bringing out a higher dose, and we try to maintain exactly the same recurrent toxicity compared to we using the regular conventional dose per fraction. Yeah. All right. Thank you. Thank you, everyone.